Hello, I'm Scott Carson, Director of the Monieson Center for Business Research in Healthcare. Recently, we invited Dr. Albert Ma to Queen's School of Business as part of our center's Economics and Healthcare Speaker Series. Dr. Ma is a professor of economics at Boston University, and he presented a working paper with the intriguing title, Uterus at a Price, Disability Insurance and Hysterectomy. After Dr. Ma's paper presentation, our Associate Director of the Monieson Center, Jeff Dixon, spoke with Dr. Ma about his work, which examines the practical and ethical dimensions arising from health insurance policy in Taiwan regarding organ removal.
Well, today you brought a working paper that has a provocative title, Uterus at a Price, Disability Insurance and Hysterectomy. And at one point in your talk this morning, when you were presenting here at Queen's, you described the situation as a well-intentioned program with stunning consequences. Tell us a bit about the policy issue you've been researching at.
This is sort of a once-in-a-lifetime kind of project. I describe it as a very uncommon natural experiment that sort of put a price on a human organ, and there's nothing to do with donation. The origin of this is in the 1960s when the Taiwanese government put in some disability insurance programs. One of the provisions of these programs is that when a woman loses her ability to conceive a baby due to one of 3 medical operations, then she's entitled to some compensation. The compensations are not very big, but they're non-trivial either. These operations are hysterectomy, which is the removal of the uterus, the ovarectomy, which is the removal of both ovaries, and radiation therapy. So the interesting thing is that these compensations are only available when these operations are done before the age of 45. Then the control experiment part comes about because not every woman in Taiwan is subject to the disability program. So there are some women who are not subject to this, and we call them sort of the control group. We're going to compare the different behaviors of the treatment groups who are subject to this disability program, or the beneficiary of the disability program, and the behavior of the women in the control group.
So what did you find in the study?
Sort of the stunning study, the stunning result is that the hysterectomy rates go up quite dramatically just a few months, maybe up to a year, before many women turn 45. Such a pattern would not be present in the control group, and such a pattern would not be present in the operation that involved the removal of the ovaries. In other words, we are finding that people, women in particular, tend to respond to these incentives by undergoing treatments, surgical removal of the uterus, at a point just before the expiration of this benefit. So the catch is, this happens right before the end of the coverage. So that's the stunning part.
The different insurance plans that you discuss in your study, as I understand, they're all public insurance plans?
They are all public insurance plans. As I mentioned, this is a well-intentioned program. Why is that? Well, we have to understand a little bit about the Chinese culture. Having a baby, having a child in the Chinese culture is very, very important. You may know, but many Chinese believe that when they get old, it will be the children who take care of them. And therefore, having enough children is very important, because this is basically an insurance policy against old age. Not having enough children is like a financial loss. And so this social program is an attempt to give some benefit to those who experience an adverse event. That's why I said this is sort of a well-intentioned policy. Furthermore, you can think about the marriage market. In many cultures, having the ability to bear a child is a desirable property for a spouse, and therefore a woman who has lost a uterus and therefore unable to bear a child would be sort of less attractive, less desirable, and that will adversely affect her opportunities in the marriage market. So again, that would be another form of compensation for them.
Now, I can certainly see this as an ethics issue that our colleagues in the Department of Philosophy might want to explore, a public policy issue the School of Public Policy might be engaged in. Why do you see this as an economics issue, and how do you approach this as an economist?
Well, in various ways, I'm certainly not blind to the idea that there should not be any price on any part of our bodies. Right? So there's very strong feelings against that. And this is the reason why in the world as we know it now, there are very few places where there are genuine prices on human organs. Right? So I can mention some examples where human organs have prices, but perhaps this isn't the right occasion to mention them. They're all related to sexual reproduction too. But I can understand the concern. So it's like a violation of a woman's right. Okay. But sort of we economists are a little bit of blind to feelings. We are more sort of rational. We like to look at data. We like to look at outcomes, and we sort of do the analysis. We have data. This is National Health Insurance in Taiwan provide all the necessary data, and we have the identities of the women. And we can look at what they've done, what the experience in surgeries are. Okay? In many countries, the lifetime risk of hysterectomy for women are somewhere between 10 and 15%, but in Taiwan it's up to 25%. So can we have some rational explanation of that? Do we know that we can find some systematic way of assessing that increment in hysterectomies is due to this particular program? And I believe that we are able to do something like that. We're able to produce some fairly convincing evidence that there has been a shift in behavior, that the hysterectomy rates have gone up, and they have particularly gone up just before the expiration of the benefit. So economics has a lot to offer because we rely on econometric techniques, which is sort of ethically neutral, and we don't sort of rely on feelings or established principles. We let the data do the talking.
Yeah. You said this is in many ways a matter of decisions, and we all have a way of making decisions about how we purchase an iPhone or purchase a car, and maybe we might apply some of that to how we make decisions about organs. So what did you mean by that, and tell us about that?
Yes. Let me relay that to one aspect which I haven't quite come to. I mentioned like 3 kinds of operations would lead to eligibility of benefit. Hysterectomy was one of them. The removal of both ovaries was also one of them. However, we do not find such evidence. We do not find such a big pattern change in behavior in oophorectomy. Right? So this is very interesting, and this is a very critical point. The way we understand it, the adverse health outcomes due to removal of ovaries is much more serious than the removal of the uterus. And the compensations are the same, but one has a more sort of disutility, more pain and suffering and bad consequences. The other one has less. And we do find that the one operation that has less severe consequences have responded more to this incentive program, not the other one. And so the contrast of these two give us sort of the evidence to make the claim. We also look at related surgeries. There are many ways to to sort of alleviate pain and suffering to a woman due to uterine problems. And these other operations are not subject to the same pattern, right? So this is a sort of convincing story to tell because of the contrast between this particular operation, hysterectomy, and other related operations.
You spoke as well about the importance of information, but the big question that arises, can we trust people to make the best decision even if they have the right information? Why is that an issue?
That is a $6 million question, right? So many health economists, many people, journalists, policymakers are worried that consumers don't have the right information, don't have enough information to make the right decision. I certainly believe that information is certainly very important, very critical. I certainly would like to know more about the consequences of even a minor steroid injection to alleviate some pain on my arm before I want to go through the procedure. I think the real issue is whether we are given the right incentive to acquire the information. So information is a lot. These days you Google anything, you get thousands, millions of results. Information is for a lot of the population in the modern world. Information is not the lack of information, but where is the information? What is the right information for me, for anybody who is going to go through whatever decision process? Okay, so are people given the right incentive to acquire the information? That seems to be the critical issue. I think that the role of a government, the role of a policy reform is to make sure that people have the right incentive to acquire the information. Guide them to make the right decision by getting them the right incentive to acquire the information. I think many health plans are beginning to do that. They give many web pages that allow enrollees to assess their situations. Many drug companies are putting out many websites so that people can assess what kind of medication will be good for themselves.
The situation in Taiwan, the policy that's in place, is it a case of induced behavior? This
is a very good question, and this is an issue that at present our data would not be able to answer. So as I said before, we are sort of data driven. We look at facts and we let the data talk. There are no data that talk to us about inducement at this point, for the simple reason that we don't know enough about the interactions between individual doctors and individual patients. Further down the road, if we manage to get more data, more micro data, maybe if I could hide a camera inside an examination room, inside an office, maybe we could do that, but I don't think I can do that.
Where could your research go next?
Our plan right now is to look at individual data to see how we can tease out the decision process. We are going to think about an episode of hysterectomy from the beginning to the end. The beginning is an onset of the risk of a certain procedure, and then we're going to assess how the patient and the doctor will come together to a final decision, whether there is no hysterectomy or there is a hysterectomy. And this is what we usually call a sort of a survival analysis. So think about, I have some problem, and I know that there's a problem. As time goes by, more development happens. I receive more information, and maybe the doctor gives me more guidance. And in the end, I make a decision. Should I go for an operation, or should I just let it be? Or should I find alternative treatments? At the end of this sort of episode, there will be either the end of the data point, there's no operation, or there has been an operation, and we want to know what brings us to this conclusion. So this will be our next step in the research to find out about this decision process.
Very good. So to what extent do you think, is this a localized issue for Taiwan, or do you see applications to the US, to Canada, to elsewhere?
This is a very hard question. as I mentioned before, the situation is very unique. Putting a price, almost a price, on a human organ. It happened in Shakespeare, The Merchant of Venice, but other than that, I'm not aware of any other disability or insurance program that would do that. So mind you, there are very common disability programs that put that put a price on an arm, on an eye. If you have an accident and you lose the use of your hand, you get paid $10,000, $25,000. But in some sense, those prices are too low. Those organs are too important. Your arms are typically priceless. Mm-hmm. So we don't usually think about it as a meaningful experiment to think of. In a sense, this is unique, but in a sense, this is also quite important because eventually, maybe sometime in the future, there is going to be a market on organs. There may be financial transactions that lead to donation of a kidney, some parts of a liver. Maybe the price of blood donation will be revitalized, or bone marrow transplant, or at this point maybe not a lung. So this will be used as at least an example of what the responses can be. I think the research is steering us to believe that people are making serious decisions. There is a response in hysterectomy. There is no response in the removal of ovaries. One consequence is less serious than the other. Fix the benefit. One response is very evident. The lack of response of another is also very evident. So I think that's a sort of promising idea. That's a way to say that we can sort of trust people to make the right decision.
Well, I'd be remiss having a guest like yourself, a health economist, engaged in health policy issues as well, and joining us from the U.S. If I didn't ask your thoughts on Obamacare, what's your read on what's happening in America right now?
I think it was a great event. I think I was talking about Taiwan. Before 2014, Taiwan was the last country to have instituted national health insurance, and now it's the United States of America. I think we deserve it. I think there are various things to sort out. The health exchange is sort of a unique institute, nothing like that, except maybe possibly Switzerland. But the amount of organization, the amount of care that has been put in is quite enormous. And most important is sort of mobilize all the sort of health economists to be engaged in this exercise. This is a very valuable occasion. Already we are seeing many research papers getting information about health exchange, insurance policy. Furthermore, many changes will happen. I myself am engaged in various research about organizational structure. One of the things that has not been mentioned a lot in the media and even in healthcare policy discussions is that the Center for Medicare and Medicaid Services has been promoting a different kind of healthcare organization called accountable care organization, which is sort of tries to get a group of doctors together so that they work together as a team, as a partnership, and is supposed to make better care decisions, coordinate their care. I and medical officers and I are sort of engaged in setting up models to study how these expert organizations should work together and how incentives are to be aligned.
Well, very good. It's been an honor to have you here, Dr. Ma. We're joined by Dr. Albert Ma from Boston University as part of our Economics and Healthcare Speaker Series, and has been brought to you by the Monieson Center for Business Research and Healthcare. Thank you, Dr. Ma.
It's been a pleasure.